عايزين نروح لللكشر بتاع التوبيك الرول of clopidogrel in the management of acute coronary syndrome patients وهيقدمه أستاذ الدكتور عمرو جمال.
Thank you. I know that we are late. We are about 75 minutes late, but I will conclude the whole story of Plavix in 10 minutes, inshallah. First of all these procedures need antiplatelets, most of the procedures, and we know that the historic antiplatelet is the aspirin, and then when we shifted to thienopyridines, the second generation is the Plavix or the clopidogrel. This clopidogrel is mainstay in treatment and cardiovascular interventions. We will speak about efficacy, safety, and role in acute coronary syndrome. We also will discuss who, where, when, and how to administer Plavix. So firstly, if we speak about atherothrombosis, a generalized and progressive disease process, we use this model in order to know how the atheroma propagates by deposition of LDL cholesterol in the subintima and then progressive narrowing causing chronic stable angina of the vessel, or plaque rupture that cause unstable angina or myocardial infarction. It can cause also ischemic stroke, TIA, and vascular death. And the platelets play a major role here in three successive things, which is the platelet activation, the adhesion, then the propagation, forming the white thrombus. Then a fibrin will come and adhere to the platelets, forming the red thrombus. Atherothrombosis is often found in more than one arterial bed. So usually cardiovascular is associated with cerebrovascular or peripheral vascular disease, and there is about 26% of patients have manifestations of atherothrombosis in more than one arterial bed. And this risk is very important because any patient with previous atherothrombotic event have a higher risk for future events in the future. So ischemic stroke patients have 2 to 3 folds increase in myocardial infarction, 9 for re-stroke, also myocardial infarction 5 to 7 folds increase in the re-infarction, and 3 to 5 folds in the risk of ischemic stroke. So what clopidogrel in unstable angina, non-ST elevation myocardial infarction, we have the large door that opens or that makes the Plavix to enter into practice, which is the CURE trial. This CURE trial was done on patients with unstable angina, non-ST elevation myocardial infarction, and they tested the primary outcome by management strategy in those patients who receive aspirin alone or aspirin plus Plavix, and these are all patients showing 20% relative risk reduction in the group that received clopidogrel or Plavix. This is also for medically treated people, for PCI group, and for CABG group. So all types of patients receiving clopidogrel in the setting of unstable angina non-STEMI showed benefit from the combined dual antiplatelets. The Clarity is a landmark trial done in patients with STEMI, ST elevation myocardial infarction, and it's a landmark trial. So those patients received clopidogrel. The primary endpoint was occluded artery. It was significantly lower odds ratio, relative risk reduction in patient receiving clopidogrel that is maintained over 1 month with 20% odds reduction for the clopidogrel arm. Also, the Clarity TIMI 28 showed clopidogrel improved the coronary perfusion versus placebo or aspirin alone, and also reduced clinical events by 20% at 30 days, as we discussed. The COMET is another trial. It is a very large trial conducted over 1,000 of patients, 46,000 acute myocardial infarction patients, and those patients receiving Plavix plus aspirin showed 9% relative in the COMET for death, myocardial infarction, stroke, and the whole mortality reduction, relative risk reduction of 7%. This is for patients in ST elevation myocardial infarction. As regard the major bleedings, there is no major bleeding documented placebo versus clopidogrel in either the Clarity or the Comet. As regard the major bleeding or TIMI-3 bleeding, most of these are non-significant placebo, I mean aspirin versus clopidogrel and aspirin together. For the CURE trial, also conducted on the unstable angina patients, the major bleeding was noted first, and this was assumed to the aspirin dose. So patients who received lower doses of aspirin, 75 to 100 milligrams, showed less bleeding rather than those who received 325 milligrams of aspirin. So the aspirin is the person, the bad guy, not the clopidogrel. For 2012 guidelines, the American guidelines updated the unstable angina guidelines, showed that people who underwent invasive strategy, I mean PCI, initiate anticoagulant therapy. Then this is a class 1 indication, and acceptable options either unfractionated heparin, fondaparinux, or bivalirudin. And for the pre-cath, add a second antiplatelet, which is a class 1 indication, level of evidence A, and clopidogrel comes here a class 1 indication. Class 1 indication with ticagrelor, which is not still available in Egypt. For patients who are treated medically or in conservative treatment, also clopidogrel is a class 1 level of evidence B drug. So it's a cornerstone in the management of patients with unstable angina. For patients with primary PCI or ST elevation myocardial infarction, it's a class 1 indication, level of evidence B, to give the patient clopidogrel 600 milligrams for patients undergoing primary PCI. So this is 600 milligrams in primary PCI. And for a maintenance treatment after PCI, it's a clopidogrel 75 milligram daily as a class 1 also indication for maintenance for 1 year. As adjunctive treatment after fibrinolytic therapy, clopidogrel is unique here. So it's the only anti-platelet that is recommended in patients with fibrinolytic therapy to be given for patients more than or less than 75 years in a dose of 300 milligram loading. For patients with more than 75 years, no loading, and just start with 75 milligram. For the maintenance, it's at least 14 days and up to 1 year. But for the 1 year, it's a class evidence. The evidence is class 1 C. For the 14 days, it's a class 1 A. And this is different in the European. For the European Society of Cardiology, they prefer to give the patient class 1A for 1 year of Plavix. With fibrinolysis, as we said, we start aspirin indefinitely and clopidogrel for at least 14 days and up to 1 year. Our 1 year is 1C, and I myself do for 1 year in patients with fibrinolysis. So when to give clopidogrel? When? Clopidogrel pre-treatment in patients undergoing PCI, the meta-analysis showed that all pre-treatment with clopidogrel in PCI CURE, CRIDO, PCI Clarity, overall it favors the pre-treatment with clopidogrel for patients to reduce myocardial infarction before PCI, and for patients after PCI, it also reduced death and myocardial infarction. So clopidogrel pre-treatment is encouraged. So please give the patient his Plavix in the ER, not late, in order to get more beneficial effect. For the CURE here, the impact of early initiation effects on stroke, myocardial infarction, CVS death, and severe ischemia at 24 hours, there is a 34% relative risk reduction with the initiation of pre-treatment clopidogrel and aspirin from the start, and this effect is usually seen and being most manifest within 1 day. It's again here about 18% relative risk reduction in patients with pre-treatment 3 to 24 hours prior to PCI in a dose of 600 milligrams. What about the major and life-threatening bleeds? The bleeds within 7 days of CABG surgery, according to the cure, there is no significant difference between placebo and clopidogrel if we stop the Plavix 5 days. But if we do CABG and the patient is less than 5 days, there is minor or modest increase in TIMI major bleeding, but there is no major or life outcomes by CABG could be balanced by that. Those even on clopidogrel, they benefit significantly with relative risk reduction from 16.7 to 13, and this for patient who underwent CABG. So even your patient, if he is going to CABG, he will benefit from pre-treatment with Plavix. So when early clopidogrel benefit emerges after first 24 hours, as we said, all the trials need to start clopidogrel early 2 to 6 hours pre-PCI to get post-PCI benefit. Benefit seen in CABG patients also pre and post-op. 50 to 60% usually of the patients do PCI, 10% get CABG. And the trade-off per 1,000 unstable patients, that early treatment prevents additional 10 to 12 major cardiac events versus creating one extra teeny minor bleeds post-CABG. So give your patient Plavix even if he is going to CABG. There is some entity which is the CABG patient who are known to will have a CABG. Like patient before has three vessel disease or left main, and he come to you in acute coronary syndrome. You know that he is a 3 vessel disease. Don't load him with Plavix because he usually will go to CABG. What about how to give clopidogrel? So what dose of clopidogrel is efficient? This trial, the ALIDA-2 trial, makes the patients with stable coronary heart disease or non-STEMI prior to PCI and randomize them to high loading dose of 600 milligrams versus 300 milligrams, and the 600 milligrams carries very beneficial effect in reduction of primary composite endpoint of death myocardial infarction target vessel revasc at 30 days versus 12% of patients who received the ordinary 4 tablets. The current also showed that 600 milligram loading dose shows 48 relative risk reduction versus the standard dose of 4 tablets. So give your patient please 8 tablets in order to prevent the stentus thrombosis. What about the current RACES 7? This trial was a moderate-sized trial done on patients with unstable or STEMI patients, and early invasive strategy randomized to standard dose of clopidogrel 300 versus 75 maintenance and 75 milligram maintenance versus 600 loading and 150 milligram maintenance for the first week. And overall, there is no difference between the standard and double dose. However, for the PCI group, there is a slight benefit in patients receiving double dose for the maintenance for the first week. What about the clopidogrel resistance? The clopidogrel resistance showed us that it's a very variable from one patient to one patient, even in the same patient, and this is the normal in medicine. So variability is normal in medicine. And what to do in such patient? We have to know that clopidogrel metabolism is dependent on a very important enzyme, which is the 2C19. This enzyme is a key enzyme in the metabolism, and those who have a loss of function of this enzyme have a variable and inefficient active metabolite generation, and of course variable and slow inhibition of the platelet aggregation. This was noticed first in the Triton TME38, that they found that these carriers of the allele of the loss of function of C219, these carriers have a higher incidence of cardiovascular death, but fortunately the cure, they have such polymorphism, and they found that the carriers and non-carriers of loss of functions, usually you can look here at the hazard ratio, they have similar hazard ratio. So if you initiate the dose of Plavix at 600 milligram, so this difference will melt down. And of course, this very elite trial found that tailoring clopidogrel dosing with platelet function monitoring can result in prevention of any stent thrombosis. The same was for Gravitas trial that failed to found higher doses of reloading of the drug versus standard doses. This makes also nonsense for the recommendation for genetic testing. So genetic testing is just a class 2B recommendation, and it comes here in the American College of Cardiology like a soft recommendation, not stressed upon. What about the use of proton pump inhibitor? There is no difference. Just 1 minute. There is no difference on the use of proton pump inhibitors for the patient as regard the cardiovascular events. So there is no problem to use omeprazole in order to prevent GIT bleeding, and omeprazole will improve the GIT events in those patients, especially those who will receive triple therapy or also anticoagulant plus the antiplatelet. So if there is a need for antiplatelet, assess the GI risk factors. If there is Helicobacter, treat it. If there is ulcer or active disease, just give proton pump inhibitor and you have no problem with your antiplatelet. Finally, we have the DAPT trial. This DAPT trial is underwent in the Harvard Clinical Research Institute, and they will ask a very important question: should we stop at 1 year or we will continue? And it's still on the pipeline. We are waiting for the results. So we randomize the patient for 1 year. Then after that, we will open the randomization. 50% will underwent 18 months and extra 18 months of treatment, and 50% will stop. And we will see comparison between also prasugrel, aspirin, clopidogrel aspirin, and aspirin alone, and we are waiting for the results of this. So to conclude my speech, clopidogrel in acute coronary syndrome, every patient for unstable angina, non-STEMI, invasive and conservative, those will go to the cath lab, or we will do conservative treatment. STEMI patients, either PCI patients, the fibrinolytic group, or medically treated group, who will not for the planned CABG, only the planned CABG. If you know your patient will go to CABG, where in the emergency department, not in the cath lab, not after 1 year or 1 month, on emergency department. When early and late for up to 1 year, and how, as we said, 300 milligram for those patients who were treated medically, 600 milligram for PCI patients. By note, this is not Venice, this is Alexandria, but before what happened. Thank you.